Welcome back to Pediatric. I'm Zach Hodges.
And I'm Al Shanklin.
And today we're excited to speak with Dr. Matthew Borgman on the topic of hemorrhagic shock resuscitation. Dr. Borgman is a professor of pediatrics in the Division of Pediatric Critical Care at the University of Texas Southwestern, here with me in Dallas. Dr. Borgman graduated from the Uniformed Services University, and he completed his pediatric residency at Brooke Army Medical Center, followed by a fellowship in critical care at Boston Children's Hospital. He's also the former national chair of the Pediatric Trauma Society Research Committee and has co-authored the 2022 Pediatric Trauma Hemorrhagic Shock Consensus Conference recommendations.
Yes, we've got another consensus recommendation author here with us today. But in all seriousness, Dr. Borgman is a fantastic resource, and in these high-stakes, high-reward patients, we are so excited to chat with him.
Yes, let's get right to the content. Matt, to get things started, will you tell our audience something about yourself and include something you enjoy outside of medicine?
Sure. So I'm a PICU doc. I actually just recently got up here to Dallas at UT Southwestern Children's Medical Center this past year after serving in the military for about 25 years in various places. So that said, my interest in research has primarily been in trauma and resuscitation and that sort of thing. And let's see, outside of the military, I got 4 kids, so they're kind of my primary extracurricular activities in terms of shuttling from to and fro and all that kind of stuff, like I think many of you all deal with. I like to cook, and so I'm cooking dinners for them. And then if I can get some free time, I try to get outside and run or bike around a lake that I live nearby.
Oh, well, that's lovely. And you must be very busy.
Yes.
So how did you become interested in trauma resuscitation, and what are your current areas of research, professional involvement, things like that related to this topic?
Yeah, so it started as a resident, as a PEDS resident, so looking for a research topic, and I got connected to my mentor, Phil Spinella. So some of y'all may have heard of him. He's kind of big in the PICU research world. So back then, he had just gotten back from a deployment to Iraq. He was in Baghdad and was kind of with a group of guys that were really interested in research and did a lot of data collection. And so he came back really excited about and interested in whole blood as he saw the use of that over there and wanted to do some more research in that. So they had a pretty good data set in terms of the stuff they collected. And so when I approached him about it, in terms of I was interested in the PICU and wanted some research ideas, he's like, oh, well, we got this great data set. Why don't you take a look at blood products in this data set? Because I'm going to be doing this study on looking at whole blood. And it really just took off from there. So I looked at that data set, and that kind of turned into ironically, a really big paper that kind of took off in terms of defining, this ratio of, using 1:1:1 in terms of blood products and RBCs and plasma. And then, I think with the success of that, I got excited about it and kept on in that area.
That's amazing. And some foreshadowing for what we're talking about today. Before we jump into the topic and Alice gives us our case, Matt, any conflicts of interest to disclose?
No longer. I forever had to say I was an employee of the U.S. government. My ideas do not reflect that of the DoD, but now that I'm retired,
Yes.
I don't no longer have to say that. So that's kind of nice.
Excellent. All right. So let me bring us in with our case here. We've got a 4-year-old brought to the emergency department after a motor vehicle collision. She was improperly restrained and now has bruising across her abdomen. She also has a cervical collar in place. She spontaneously opens her eyes and is moving all extremities purposefully. She is tachycardic, her extremities are cool, and she is still normotensive. 20 per kilo of crystalloid is administered, and she is yours to resuscitate. So, Dr. Borgman, before we get into the management of this case, how do you define hemorrhagic shock in children? Does this patient have hemorrhagic shock?
Yeah, so hemorrhagic shock, I think, we need to define it as life-threatening bleeding. And, the challenge with kids is, how do you know at that point bleeding becomes life-threatening? So there could just be the obvious looking at them from afar and seeing blood everywhere and like, oh, this is an emergency, this is life-threatening bleeding, they're in hemorrhagic shock. Or they could have, internal bleeding. So this patient is tachycardic and normotensive. So based on our classic definition, she's in a potentially compensated shock state, right? So presumably her tachycardia is from bleeding, but that said, she could also be in pain. So you do have to kind of sort that out, right? But I think you could go on to ask, well, how much blood had they lost? And, when would they become hypotensive? I think as fellows and PICU people in general, we know that classic graph, right, of blood loss compared to heart rate and blood pressure, right? And it kind of stays flat for blood pressure until they fall off the cliff. Somewhere around like 30% of the blood volume. But, just looking at the patient standing at the bedside, you really don't know where they are at on that curve.
So is it fair to say that before a patient would become hypotensive from hemorrhagic shock, they might have lost 30% of their blood volume? Is that fair to say?
Yeah, I think that's fair to say. So, you really just have their degree of tachycardia prior to that. Again, you might have some indication if there's blood that you can see, but for internal bleeding, you really don't.
Oh, absolutely.
And I was going to say, if someone does show up to the emergency department, the trauma bay, and they're hypotensive from hemorrhagic shock, a child, what's the associated morbidity, mortality of something like that? I imagine that's extremely high risk.
That is high risk. It's going to be higher for kids and adults. So, their 28-day mortality is going to be around 36 to 50% in kids. And that's, almost twice that for adults, which is around in like the low 20s. So obviously those are kids that you need to, immediately react to and start resuscitating.
Oh, that's important, especially as PICU fellows that go down to the trauma bay during all of these trauma stat with the general surgeons there, thinking to yourself, this patient is hypotensive and 60% mortality is huge.
Right. And so, good to remember too what your normal blood pressures are going down there in case it's more of an adult-based unit, right? That may not be familiar with, age-based vitals.
Now, I've given you a patient who's tachycardic and cold, but not yet hypotensive. She's received 20 per kilo of crystalloid on her way in. What's the correct amount of crystalloid to give a child in hemorrhagic shock? Should we do more?
Well, as a disclaimer, I could say I'm someone who's very biased against crystalloids, so you may get different answers when you talk to other people. But I would say the correct answer is none, if possible, right? Because with trauma, just as we've seen in pretty much every study that comes out when you're looking at sepsis or kids on events, the more and more fluid they've gotten is always associated with badness. Of course, is that because they needed it or not? But, I think in general, crystalloid does bad things in trauma. So, yes, I would say the correct answer would be 0 if that's simply the question you're asking me.
And will you explain, what bad things does crystalloid do to patients that are bleeding?
Yeah, so in those like retrospective studies that, that many that are out there, you're going to see association with longer stays, longer ICU length of stay, more vent days, increased degree of ARDS and MODS, higher amounts of anemia, compartment syndromes, even increased infections. I looked at one study just looking at, doing good hemostatic resuscitation with more of a blood product focus resuscitation. But those patients who got a whole bunch of crystalloid and a bunch of blood products, you kind of negated the benefit that you got by doing a good job with the blood products. So, I'd say in a nutshell, those are kind of the main problems of crystalloids.
And for these healthcare institutions, whether it be the emergency department or the pediatric ICU, or even maybe EMS along the way, what are some practical tips to increase blood product availability to these patients who come in hypotensive and hemorrhagic shock?
Well, certainly just having good protocols for dealing with it, right? So, and that starts pre-hospital. That's not just in the ER. So, what is your protocol for, trauma activation when they're en route? There are some EMS systems that actually have pre-hospital blood products so that they're not getting crystalloid en route. They're actually getting blood pre-hospital. And then in the trauma bay, that again, it's a lot easier when you actually have blood products in a blood fridge in the ER, or at least a blood bank that's in close proximity, that you can get blood products more quickly to the patient.
Practically, what does it look like? I mean, I've heard of there being coolers or maybe a fridge in the ER. Like what is immediately available to one of these trauma patients in one of these high functioning centers right when they hit the door?
Again, that's going to vary based off of the center. And some centers, especially adult, large volume adult centers, there's increased use of whole blood, which we'll get into more later. So they may have several units of cold stored whole blood, typically group O, low titer. They may have just a couple units of RBCs and a couple units of plasma, generally not platelets because it's not cool to cool them as of yet. That may change in the future. So typically it's your, typo RBCs that they can just give to anyone hitting the door at first.
Oh, nice. And when you think about the systems in place and the way that these trauma centers will activate or trigger themselves to open the fridge and get the blood that they have in the bay, what's the intersection between that, grabbing the blood from the fridge immediately available to you, and activating pediatric massive transfusion?
Yeah, good question. The whole purpose, you need to ask, what's the whole purpose of, triggering a massive transfusion protocol? And that would be, well, you simply need to get the blood to the bedside as quick as possible. So if you have all that you need there at the bedside because you have a fridge right there and that's all the patient needs, and so be it, then you don't necessarily need to even dock the blood bank. You probably should, but that said, if you don't, you need to get those products to the bedside quickly. And so you need to tell them, like, say, activate, massive transfusion protocol. We have this size of patient, send us the first pack, so to speak. And then that gets delivered there. And then you can titrate it in at the bedside based off of what the patient looks like.
And maybe for the trainee who hasn't had an opportunity to activate a pediatric massive transfusion, will you tell us, what the thought process is when you have that patient who's likely bleeding, but this not the patient that has, there's blood all over the gurney and you see the kid's hypotensive and shocking. It's obvious to me that that patient needs massive transfusion, but like this patient, you've given that first couple of units and maybe they perked up a little bit, but there's something not quite right with their exam. Maybe they're still cool. How does an expert think about when to utilize that massive transfusion when it's not clear?
Yeah, well, probably it's best to first ask, is the patient still bleeding or not? And clearly in the way you're pitching it, you don't know, or they're likely still bleeding, right? You could have a, child coming in who's shot in the arm. That's going to be an easier case to deal with, right? Because that's compressible hemorrhage. They likely have a tourniquet in place and the problem should be solved. And that's the case you really don't need to worry about. It's more of your polytrauma, that torso trauma, pelvic trauma, where they have internal bleeding and it's not clear. I think there you're really just going off of, your gestalt, their heart rate, your vital signs and exam, and you need to activate things and continue resuscitation until, the bleeding is controlled. That may be in the OR or the IR suite for if they need embolization, but, I think before they're in those places, you're really continuing resuscitation until they get definitive care.
Nice. And then once we've made the decision to activate the massive transfusion protocol, what exactly does it include?
When we typically write transfusions, especially as a resident, we're used to doing our weight-based stuff, right? So you have a 13.4 kilo kid and you write for 10 per kilo. So you want to get that 134 mLs into the patient, right?
Mm-hmm.
You don't want to be doing math, and you don't also want the down in blood bank them to be drawing out and measuring 134 mLs of blood, in the blood bank, and then waiting for that to be sent to you. Like, that's just not practical at all, right? And that's silly. So really the whole purpose of the MTP pack and activating it is just to get the whole unit to the bedside. And then you can, based on the size of the patient, titrate it into the patient at the bedside. Centers will all have their own cutoffs and protocols in terms of how much is delivered in that kind of first pack or so. And it might be a weight-based or it might just be an age-based. So say you got kind of a school-age kid, the first pack might be 4 units of RBCs, 4 units of plasma, and then, maybe a unit or half unit of apheresis platelets to the bedside. And then at the bedside, you can titrate those in. In the big kids and adults, they might use, rapid transfuser, but in the small children, you might just be using a 60 cc syringe and doing just your push-pull thing and, doing kind of 10-ish per kilo aliquots, as you're pushing it in and just reassessing after each one.
Will you tell us more about the ratio? We've heard of ratios of like 1 to 1 to 1, thinking red cells, plasma to platelets, or even maybe 2 to 1, red cells to plasma to platelets. I guess that would be 2 to 1 to 1. What ratio is generally preferred in hemorrhagic shock in context of trauma?
Yeah, so I was part of a guidelines conference about this, just a couple years ago, and so I'm guessing you'll, maybe have a link to that in your comments.
Oh, yeah.
But,
Sure.
put out in the, the Journal of Trauma. So, as we got together and talked about it, there's obviously limited evidence. A lot of our stuff is based off of retrospective data. But in that, we, suggested to target, the 1-to-1 ratio of RBCs to plasma, RBCs to platelets, based off of the limited stuff we know at this point. Classically, regarding the platelets, in adults, in terms of the adult studies were done, they're talking 1:1:1 in the context of a platelet concentrate. So, you have like a 6-pack of platelets. So 1:1:1 would just be 1 pack, not a whole 6-pack. So technically for them, it'd be, 6 units of RBCs, 6 units of plasma, and then a 6-pack of platelets. If using apheresis platelets, that's drawn out a little differently. So that's why when you're hitting 4 to 6 or so units of RBCs and plasma, you should be kind of giving about a unit of apheresis platelets along with that. But again, this is suggested. This is based off of expert opinion and retrospective data. There's certainly probably more to come in the future.
I'll admit that I don't understand enough about blood product transfusion and how the blood bank works and massive transfusion. It's great we're having this discussion today. When I think about ordering blood products, I always think about ordering in volume, 10 to 15 per kilo of red cells, 10 to 15 per kilo of plasma, 10 to 15 per kilo of platelets. So if I have this sick trauma patient in front of me and I'm pushing in red cells, pushing in plasma, like at what volume of red cells and plasma should I start incorporating platelets, and what volume would you typically provide?
I mean, if you're giving, I think just a couple units of RBCs and plasma, that would be, say, for the small child, you'd probably be considering giving around have a trigger to give a half a unit of apheresis platelets there, at least to get it to the bedside and then titrate it in based off of the 10 to 15 per kilo aliquot that you're delivering. So I would say, if they've given, at least 2 of each of RBCs and plasma, I think you should be thinking of apheresis platelets. The protocols often is going to be RBCs and plasma in that first pack, and then if you're calling for the second pack, they'll deliver apheresis platelets with that, and then you would just titrate it in at that point. It probably will come in your second pack, or it might come in your first pack.
Yeah, I've had that experience too, where I'm looking at the first pack and I'm like, okay, no platelets yet, and then it comes later.
Yeah. But again, this is a much different strategy than was classically done just, maybe 15 plus years ago, where we gave platelets based off of drawing a CBC and seeing what the platelet count was, right? And who knows whether that platelet count was reflective of what the true platelets are when the results came back, an hour later or whatever it was.
Yeah.
And, as you recall, platelets are important for bleeding, right?
Right.
So.
Yeah. What I really appreciated about the Pediatric Traumatic Hemorrhagic Shock Consensus Conference recommendations from 2022, which I do think all fellows should sit down and read, is that you guys didn't pull any punches with your statement. You give 1 unit of RBCs, you give 1 unit of FFP, right? You need that high ratio, you need that 1-to-1 ratio. We all talk about balanced transfusion, massive transfusion, but when you look at those guidelines and it says, okay, you've given a unit of RBCs, you give a unit of plasma. I really appreciated that.
Awesome.
So when we were preparing for today's talk, looking at maybe adult studies in addition to kids, there was this concept of permissive hypotension in the trauma patient. And I'd just like to know, as a pediatric intensivist and a trauma specialist here, like what hemodynamic targets do you use to guide your blood product transfusion in these trauma patients? And is permissive hypotension even on your radar for kids?
Yeah, I mean, it probably shouldn't be. And, we don't make recommendation for it in our guidelines. I would say this, I think even in the adult world, it is controversial in terms of using it. And the concept for it is that the adults like to use this concept of popping the clot. Clots form if they're bleeding, and especially in this low flow state. And if you kind of increase their blood pressure, just like when you're worried about bleeding in hypertension, maybe they would have less bleeding if you don't shoot for normal. I think in a patient that's in front of you, obviously if they're hypotensive, you need to act upon that. Just as we said, they've lost at least 30% of their blood volume. So I'll say this. So first of all, is it a TBI patient or not? First of all, right? If it's a TBI patient, remember the 2 most important things for TBI patients that's associated with bad outcomes is 1 is hypoxia, obvious, right? Brain needs oxygen, but 2 is hypotension. So you got to address hypotension first and be aggressive with that, right? All of our TBI patients need a good cerebral perfusion pressure. And then 2, in terms of guiding resuscitation, is kind of what I was getting at earlier, right? Is the patient still bleeding? So is this compressible hemorrhage? Is the bleeding controlled? Do they have tourniquets on? Or is it non-compressible torso-type trauma? And there I'm looking at, that heart rate, probably more the heart rate, right? The heart rate trend. Again, is it pain-related or not? But is that heart rate trending up? If it's trending up, I'm worried about continuous bleeding, right? So maybe permissive tachycardia would be a better term to use. So not that we want to, because we don't necessarily going to get a perfect heart rate, right? Not going to get it down to, 60 or 70, but, a little tachycardia is probably okay. But a heart rate trending up is bad, but, responding to your intervention and coming down and then staying down some and not going back up is probably how you want to titrate your blood products there at the bedside.
I think it intuitively makes sense. If your patient's heart rate's improving, their mental status is sharp, and they're warm distally, it makes sense that you're heading in the right direction. And the inverse of that, if maybe the mental status is slipping and they're hypotensive and heart rate's going up, it seems intuitive they need more blood. Is there any evidence for supporting the use of biomarkers like lactate or base deficit in these trauma patients to guide resuscitation?
Yeah, I think probably as an initial trigger that it's going to be a sick patient that needs resuscitation. So, I was part of some research looking at base deficit and INR, as a marker of coagulopathy. So patients that had, higher base deficit and higher INR, were, at increased risk of having bad outcomes. So, if you have that early on, I think that's a trigger for being aggressive and that this is going to be a sick patient that needs resuscitation. I think repeated lactates, I don't think that's typically used in the setting of hemorrhagic shock. I think we're really going based off of these other things that I was talking about. And, if you can get some sort of stability, typically they're able to go to the scanner then, and then you see what's going on inside, and then the surgeon makes a decision of whether they need to go to the OR suite or the IR, or they're able just to be watched.
And then last follow-up question before I turn it back over to Alice. When I think about shock in the ICU, I think about the luxury of having NIRS monitoring. And I think you're going to tell me that the data's not out there yet, but is there any data on using NIRS in the trauma bay to get an idea of oxygen delivery debt?
Yeah. I think there may be some with, maybe with TBI and your TBI resuscitation, so it might be helpful in that setting, but no, there's no good data. I mean, I think there's similar data with cucumbers, right? So,
NIRS on a potato, yeah.
Or a potato, right?
Yeah.
So I wouldn't necessarily fixate on NIRS in the trauma bay, I guess would be my bottom line.
The theme I'm hearing here for a patient that's actively bleeding is that follow your heart rate, your physical exam. Literally everything else is too late, right? Blood pressure too late, lactate too late. By the time you get the NIRS on, maybe also too late.
Right.
The other thing that we've heard about in trauma and that you mentioned in those consensus recommendations is to consider low titer group O whole blood or LTOWB over the individual blood components. If it's available, whole blood may have a benefit. Can you explain what this is and then what the culture is in pediatric resuscitation? Do people have whole blood available?
Yeah. So a survey that was done back in 2009, I think it was, showed that about 30% or so of 15% of children's hospitals had it available. So that was 2009, so the number might be higher. And I'm also not sure what proportion of those are actually in the ER, because that may just be in like the cardiac OR or something where there's a little bit more historic use of it. But that said, given recent pushes, the number again might be a little higher. What's the benefit? Well, think about it first. You're giving a unit of whole blood. What does a whole blood have in it, right? Well, it's got everything, right? What you bled out is whole blood, and so maybe intuitively makes sense to give you back out what you bled. If it's got RBCs and plasma and platelets in there, it's just easier because, kind of fixes your question earlier, Zach, about, when should I give platelets or not? Well, if you're giving whole blood, it's there, and then you don't have to worry about that question, right? I mean, how do we first get in this predicament anyways? Well, this was back, right prior to the Vietnam War when we figured out how to separate blood products and we had better kind of plastics and storage. So just logistically, we started separating out blood into its components and then delivering the individual products. And so that's from really then on was how we gave blood products. And, there's also some, unfortunate move at that time too to get your large bore IVs in and just give your 2 liters of saline to these patients. And, that has also not turned out well. Prior to that, so back in World War II and always before, and in many third world countries now, we're giving whole blood. So one is that, again, you're giving everything at once. So is giving everything at once have an advantage? Well, it actually does when you think about it, right? Because if you have a bleeding patient, that's especially when it's coagulopathic, you want to fix it, right? And you want to fix it soon. So if you were to order RBCs and then order plasma and then order platelets and then run those, in sequence, one after the other, it's going to take a while to restore them back to normal if that's all it took, compared to just giving your 1 unit of whole blood. So there's some advantages there, so you potentially better outcomes because you're restoring the coagulopathic problem quickly. So definitely logistic advantages there. There's less volume, right? and giving just your 1 unit of whole blood versus the 3. Each of those individual components, so the RBCs, plasma, and plates, are all going to have some stuff in there, right? Some anticoagulant and stuff in there to store them. And so there's going to be over 3 times the amount then when you're adding all those together that you're giving to a patient, right? So giving more anticoagulant to a bleeding patient is probably also not good. A lot of those anticoagulants often are containing citrate, right? So citrate reduces calcium. So that's an important point for fellows, right? To know that you need to be paying attention to calcium. So you're potentially getting more hypocalcemia by giving individual components. There's likely less ABO incompatibility because you're always giving type O as opposed to, say, matching products. So they found that definitely not more hemolysis, but the same or potentially less hemolysis. Also, it's cold stored whole blood, right? And so started getting at this earlier, but platelets are still at room temp. And so being at room temp right now, there's a shorter storage life, but also there's a higher risk of bacterial contamination. Now, if you're giving platelets through cold stored whole blood, there's potentially less risk of infection and contamination compared to your warm platelets that maybe, got some degree of bacteria in them. Yeah, so I think all together, there's, I think a big push for for doing whole blood, versus all the components.
Matt, it seems convincing that whole blood has many advantages compared to delivering the individual components. And we'd like to know, what are the limitations that's keeping it from being more widespread?
So first, it's just a big culture shift, right? This hasn't been done for a while. Been taking work, dealing with the FDA and, some people in the blood banking community to do that. That said, there's definitely blood banking believers out there that are also pushing for this. There's also some, logistic issues to deal with in terms of getting whole blood there, in terms of the storage of it, because you don't want waste, right? That said, the centers that have been using it, I think, have figured out, the workarounds around that and how to, rotate use of it from the ER bay to use in a hospital to minimize waste. But I think that, the question is also, is it better? I rattled off a whole, bunch of reasons why it might be better, but we don't necessarily have that data yet. Some of you out there, may be participating or getting ready to participate in the MEDIC-2 trial. So this is massive transfusion in children. So I mentioned Phil Spinell is, one of the main leads on this out of Pittsburgh. And so the initial study, the MEDIC-1, was really to get all the baseline data in terms of outcomes and how much is transfused at different hospitals and, all the associated outcomes. So that was really the epidemiology and looking at, how many centers have massive transfusions, what are their outcomes. It was a prospective study, and so they found associations with, certain things. And so we used some of that data to inform our guidelines. This new study is really going to be a head-to-head study of whole blood compared to component therapy. It's a massive trial, multi-center. It's going to take a little while to complete, but that'll really give us the ultimate answers and hopefully, as we move forward. And I think sometimes it just takes solid data to change the culture, so that this may be that.
And I guess a question in a similar vein, are there any prospective, randomized controlled trials of whole blood versus component therapy in kids, or not quite yet?
Not quite yet. So that's this one. There's, there's some cardiac literature, like I alluded to way back when, but, really for this context, it's hard to do big randomized controlled trials in kids. And so, this MEDIC-2 trial, I think, is going to be the main one.
Before we move on, we've talked about our balanced resuscitation. Is there any evidence for me also empirically giving fibrinogen or cryo to these patients? Is that part of the balanced resuscitation at all?
Yeah, unfortunately, we don't have data to say yes to that. Okay. I think that there are people, and definitely in the adult world, that will give empiric cryo or fibrinogen to your bleeding patient coming in. The best we could do in our guidelines is essentially, as an expert opinion, say that if your fibrinogen is low, give fibrinogen or give cryo, right? So, shooting for, we set a value of 150 to, replace if that's the case. If you're at some resource limited small place, I think that doesn't have the ability to measure, it's going to take a while. I would say, you might want to consider giving it empirically if you're not able to measure it, especially if you're giving a very large volume transfusion. But in the meantime, no, we don't have any data for that. There's some, potential work also looking at some thromboelastography and, maybe triggering your use of fibrinogen. But again, we just don't have the data to say empirically give it.
And we'll definitely get to TAG and ROTEM. But Matt, I'm so tempted to push you a little bit and say you don't have great monitoring and you have a patient that's in front of you and they're sick and they're bleeding and you're giving blood products. Like, do you have a threshold if you cross, 30 per kilo of red cells or somewhere in there? Do you have a spot you say probably should give some cryo at this point?
We looked at, what's a massive transfusion? I think if you're hitting at 40 per kilo of all blood products, that's about a half a blood volume of your kid. You might want to consider giving it, especially if you don't have the labs to check. In a bleeding patient before you, the harm of giving cryofibrinogen seems pretty low. I wouldn't really have a problem giving it to them in that case.
And then do you have a similar practice when it comes to calcium repletion? We've already mentioned that many of these products have citrate in them that binds calcium, and your trauma patients who are bleeding are at risk of hypocalcemia. And, as pediatric intensivists, we all know about hypocalcemia and myocardial depression and hypotension. So do you have a style for when you would replete calcium?
It's pretty easy to check calciums, ionized calciums in the ERs at, most big centers. So, you could just check it would be the simplest thing. Obviously, you're pushing me to say when. I would think after every 2 to 4, definitely 4, but I would say I would probably after, your second product. So if you're giving blood and then your plasma, you should probably consider a calcium dose. In practice, I often just do this empirically, or if I'm giving albumin at the bedside, I'll just give a dose of calcium if it's a patient I'm worried about their blood pressure. I think the harm of calcium in this setting, if they're bleeding and you're giving blood products, is pretty low, right? Because it's lower than it maybe should be if you're giving blood products. So I would have a pretty low threshold in giving it if you can't measure it.
Nice. Now, as we move down our pathway here, what's the role of empiric antifibrinolytic agents? Like, when should we be giving tranexamic acid or TXA? What do you think about Amicar or aminocaproic acid? What's the deal with those?
Yeah, so in our guidelines, we gave a conditional recommendation for it. And probably I should back up and just talk about what does it do and what's going on with the patient, right? There's been some good work, a little bit out of Houston, but even more so out of Pittsburgh. And this is, based off of Barbara Gaines and Christine Leeper's work. What is fibrinolysis? Well, remember, you make a clot, right? It's made of platelets, right? And then the glue that holds them together is fibrin. In our body, we have the normal homeostasis, and that how does the clot gets broken down? Well, we got to break the fibrin up, and that's fibrinolysis. After trauma, there's kind of different phenotypes that exist. So based on their work, about a quarter of patients actually have hyperfibrinolysis. So that's defined generally as a lysis time of over 3% at 30 minutes. And those patients actually have the highest mortality, somewhere ranging between 9 to 50%. And a wide range, but that's because it gets higher and higher the higher the degree of fibrinolysis they have. About 30% have physiologic fibrinolysis, and those have the lowest mortality, somewhere in the 1 to 8%. But they also identified this phenomenon called fibrinolytic shutdown. And so those are patients that have less than 0.9% lysis at 30 minutes. And this was actually the majority of patients, so 45%. And they had a higher degree of mortality than your physiologic fibrinolytic patients, so somewhere in the 8 to 10% range. And they were also, interestingly, more often the head traumas and the kind of the younger subdural bleed type patients when you think about it. We're not generally checking tags or whatever, so we don't necessarily know what phenotype they're in. But I think intuitively, you would guess that probably, given this high mortality for the hyperfibrinolysis patients, that that's the patients that TXA would help on, or an antifibrinolytic, just to restore them to normal. And to be fair, I'd say that giving good resuscitation with plasma platelets also will help restore that as well. So we don't have great data in kids, so the data reviewed was primarily retrospective. There's one prospective study, and these were associations. So these aren't randomized controlled trials, but they're associations with better outcomes for the most part. With the better of the studies all showed improved outcomes. The best studies have been with adults. So there's the big CRASH 2 study, which fellows should probably be familiar with. And in that study, they found that TXA, if given within 3 hours from the injury, you actually had improved outcomes, less transfusions, less deaths from hemorrhagic shock in those patients. So, we extrapolated it to our guidelines here to say that, again, if given within 3 hours from injury, to at least consider it. So it's kind of a suggest type recommendation. You also threw out some other antifibrinolytics there too. Most of the data we have, and like I mentioned, all the adult data is with TXA. So for Amicar and others, we don't have as much data. there was some suggestion of increased risk of AKI with Amicar. So given that, and given the bulk of the data has been with TXA, we suggested that if you're going to use an antifibrinolytic in this case, just to choose TXA.
Matt, I'm interested to know, are there any upcoming trials in pediatrics to better inform us on the use of TXA? And if I understand correctly, there's also a CRASH 3 study ongoing right now in adults.
It's done, actually. The CRASH 3 study is done. Yeah.
Congratulations to them.
Yeah, good for them. But yeah, that was published just a couple years ago. And so that's with TBI patients, because the question was, should you give it with TBI patients? Because that was not a focused population in that first study. And there they also found a benefit. Interestingly, it was for patients that were kind of the moderate TBI. So if they had a fixed pupil or low GCS of, putting them in that severe TBI category, you didn't see that benefit. So it was with more of the moderate TBIs that you got a benefit, which I guess makes sense, right? Because if those sick patients are probably going to have bad outcomes because of their degree of TBI. So with kids, actually the MEDIC-2 trial is also incorporating TXA, and they're going to do a lot of even some pharmacokinetic work and all that. So that will be incorporated into the study in, I think, some complicated way to give us some answers. So there are some other studies that we're trying to seek funding for doing a TXA only trial in kids, but those hadn't been funded. But I think the MEDIC-2 people were able to get it incorporated as part of their methods, which makes sense, right? If you're comparing whole blood and component therapy and some places are giving TXA, well, you really need to use that as a key feature in analyzing your data.
Oh, absolutely. And this is such a population where they're either going to be okay or they may die. And that mortality benefit, the fact that we are doing the research for that is really wonderful.
Right. Going back to what I was talking about with phenotypes too, there is some concern of giving TXA if they don't have hyperfibrinolysis. So, that might be a push for checking, first of all. But also, is there potential harm that could come from giving it if they do not have hyperfibrinolysis? Talking to some people, I think some suggest that, well, is it harmful if they have fibrinolytic shutdown? Well, they already have low fibrinolysis already, so maybe you're not making them any worse. But maybe it would make worse those patients that have physiologic hyperfibrinolysis, and you're kind of pushing them down into that shutdown phenotype, which we do know based off of our data has a higher mortality than just the physiologic group. So, I think that might be an argument to maybe check to see what you're doing before giving it.
And I guess coming on in that theme, as I understand it, the only way to be able to get an actual identify the phenotype of your patient is actually to use something like TEG or ROTEM. And if that's the case, will you just go ahead and maybe give us our introduction to what exactly that is and perhaps how it can be helpful in guiding resuscitation in these patients?
Yeah, so the great part about TEG and ROTEM is that it's looking at whole blood, right? When you do your other studies, like your classic coag studies, right, of PT, PTT, it's going to be looking at serum, and then they're going to be putting stuff in there and looking at them. And they also take a while to come back. So TEG and, the trauma centers that are using it, they often have either it right down in the trauma bay or they have a screen down there to get those results right away. You get those initial results just in minutes, which is important when you're thinking about guiding your resuscitation. There's different technology and there's some new ways of looking at it, but the classic TEG, basically you got your little vial of whole blood and there's a little pin in there. And sometimes they use activators to start the clotting reaction to take place. And either the pin may vibrate back and forth or the vial may vibrate back and forth, or it spins in a case of ROTEM, which is rotational thromboelastography. So the pin is just vibrating in that blood that's becoming a clot. As that clot forms, it'll change the vibration of that pin and then change the way that graft looks like. So based off of that, you get a picture of what the blood looks like as it's coagulating. So there's some different markers we look at in terms of the initiation of the clot, how it's forming, and then the strength of the clot at the end. And so that's where you get some of the measures you may be familiar with, like your R time, your angle, your alpha angle, and then your maximum amplitude of that clot. And then as you watch that clot over time, you should have lysis of the clot, right? Based off of our own physiology, homeostasis, so that clot, will break down over time. It will break down really quick if you have hyperfibrinolysis, and it won't break down at all if you have fibrinolytic shutdown. But especially for, your initial markers, again, you can just get them in a few minutes. So it can be a very helpful way of guiding your resuscitation as opposed to just waiting for labs to come back an hour later.
Matt, when I think about TEGs, I think about sending them down and then getting the result in an hour or so. But what you're describing is much faster. And I'd like you to tell me a little bit more. I know there's something called a rapid TEG. Are you talking about something different than I'm mostly accustomed to?
If you can log into the software for it, you can actually see it in real time and get those values right away, as opposed to like waiting for the whole thing to be resulted an hour later. So, what I'm describing, they're looking at that graph that's being formed by that pin in there, or depending on the machine, in real time. And so they'll get that data back in minutes. And so, it may just shoot right up with that value right away with the R time and alpha angle, as opposed to, waiting for that to be transferred to maybe going from your TEG software to your Epic or whatever. So there may be a delay in that. So if you really want that data, you should make sure you have access to the TEG or whatever software, or the machine itself to get that answer right away, as opposed to waiting for those numbers to be transferred over.
Yes. And then thinking about, you're the attending at the bedside, you have this patient coming up from the ER from their trauma. Maybe for some reason they're not going to the OR, either not yet or they don't have necessarily a surgical bleed, but they certainly are coagulopathic. How do you use TEG and ROTEM to guide your resuscitation? And I know it can be complex and there's many applications, but perhaps 2 or 3 lessons to share with us. How can you use TEG to guide your resuscitation?
Especially for new fellows, I'd recommend you just snap a picture of a TEG algorithm to have on your phone, or have a little card in your pocket or your badge or whatever, to just so you're familiar with the terminology and what it looks like. A lot of those values you can get back just within minutes. So the R time, the time that the clot is forming, you can have back in the first 5-10 minutes. And that's really a trigger for you to give FFP. You'll know to give FFP, a lot quicker than you would by waiting an hour or longer for the INR to come back. Based off of the alpha angle or K time, again, you'll know that within minutes, and that could be a marker of needing to give some cryo or fibrinogen. Your maximum amplitude is primarily looking at platelets. It could also be affected by fibrinogen. So, I would use that to consider giving that quick. And again, that's a number you can have back in just 10 minutes compared to waiting for your CBC to come back. The lysis at 30 minutes, again, would take 30 minutes to find out. Unfortunately, remember that TXA, you have that window of giving it within 3 hours from injury. You may get some indication that you're seeing hyperfibrinolysis before that, especially if you're looking at the printout. So, I would take a look at that. And if you are concerned that they're bleeding, you see an ugly looking figure of the way the TEG graph looks like, you even consider giving TXA before that, looking at the shape of the curve. If they're going to be an obvious hyperfibrinolytic patient, even before that 30 minutes, you'll have an idea.
That's really helpful. And, there's many steps to interpreting a TEG, and we'll be sure to include a reference in our show notes for our listeners to learn more about that. So, when we have these trauma patients come up to us from the ER, and perhaps they have a procedure upcoming, perhaps a neurosurgery wants to place an intracranial pressure monitor or something. Maybe they're going to go to the OR and general surgery is going to fix something. It's tempting to use medicines like Kcentra or Novo-7 to fix lab markers, to fix coagulopathy biochemically. Is there any value added in that, or is it hard to say?
Yeah, typically it's going to be the surgeon driving that, right? Because they're the one doing the surgery. Regarding the Kcentra or your, prothrombin concentrates, we really only have, good indication for the patients that are on anticoagulants, right? So if it's a patient on Coumadin or your direct thrombin antagonist and you need to reverse things quickly, that would be, a patient I might consider giving it to, and then placing on heparin or having heparin available, because it's always one of those risk benefits, right? So they have some mechanical mitral valve and you don't want that to clot off, because that would also be the end of the story. But if it's a massive hemorrhage, you also need to fix that so they don't bleed out in front of you as well. So you may be playing the balance game. Kcentra also has a benefit if it's a really coagulopathic kid and you're trying to limit volume, if they happen to be anuric and you don't want to necessarily flood them with plasma, because it could take a whole bunch of plasma to correct a bad INR and a bleeding patient that's getting a procedure, that would probably be a good use of Kcentra. But again, these are kind of outside the guidelines that I'm talking. Novo-7, I'm not too excited about in general giving. I think in general, people give it, and because it's so expensive, they're really giving it as kind of the last-ditch effort to throw the kitchen sink at the patient, right? I would make the big point that if your patient has low platelets and they have low fibrinogen, and especially if they're acidotic, those are these sick patients that we're talking about that are bleeding out. If you give Nova 7 to them, it's not going to do anything, right? In fact, a little bit of factor 7 or factor 8 or whatever other factor you want to throw them isn't going to do a thing if they're acidotic and you don't have platelets or fibrinogen to make your clot. So you got to think just the basics, right? So, if you were running low on plasma and you still had an elevated R time or something like that, maybe you could consider giving that in that case. But, I think it would be an unusual case to really necessitate Nova 7 outside kind of your hemophiliacs or, patients that have other bleeding disorder that you're trying to correct.
Yeah. Thanks so much for those remarks. It seems like it's an evidence light zone using Kcentra without the context of a patient on an anticoagulant, and then Novo 7, while it might be tempting to fix the numbers, it might not always be helpful for the patient.
Yeah. There was a big push, I think, especially the pharmaceutical industry was trying to make a case for it because it's so expensive. And, there's one study done for head trauma patients that the size of your intracranial hemorrhage might be a couple millimeters smaller by using Novo 7. That was the best they could do.
Yeah.
That's
Yeah.
Kind of, I think you just need to stick with the basics in general to get your best outcome.
Yes.
Well, this has been so good. Do you have any recommendations for PICU fellows who might want to become more involved in this area, especially because it does seem like there's so much research happening coming out to contribute to?
Some of the good research comes out of PLECE, specifically the BloodNet group there. So that's where the MEDIC-2 trial is coming out of, as well as there's collaboration with some other research networks. Peds Trauma Society is, maybe another good one. Probably what's important in this area is to, get outside of our silo of the PICU, right? This is really a multidisciplinary thing. And so collaborating with surgeons who have interest in this area and blood bankers with this area, connect with them, ask them about it, connect with them in your hospital when you're talking about, coming up with your protocol. And I think, your multidisciplinary collaborations are really where, some good stuff can come out of. And you learn a lot too, right? Because you're not just talking to other PICU people. Along with the guidelines, we also published a paper on research priorities. So if you just want to get some ideas of what are some of the missing holes in terms of some research ideas. Some of those are going to be, a lot of them are addressed, or not a lot of them, some are addressed by the MEDIC-2 study, but yeah, take a look at that in terms of if you want to guide that in terms of where you want to take your research.
Oh yeah, that's a great fellowship project hack.
Yeah, just Google research priorities, right? And whatever topic you are, and somebody might have even come up with a list of things for you to do.
Well, that's perfect. Dr. Matt Borgman, we've really enjoyed having you on today to discuss this really important topic. I want to leave you with one last open-ended question. Anything else that you'd like to mention before we wrap things up here?
No, I think we really hit all the major pieces. I think, the final lessons, like I started with the beginning, right? Avoid crystalloid. Don't flood your patients with crystalloids. Push for doing good blood product resuscitation. Be on the lookout for, the MEDIC-2 study and the use of whole blood, and maybe be an advocate for that because, I believe that's the direction we're going to be going in the future.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review on your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.